A very good evening to everyone. I am Dr. Keerat Sibia, consultant pulmonologist from SPS Hospitals at Ludhiana, and I welcome you all to today's webinar that is Back to Basics in Chest Radiography. Today is World Health Day, and when the topics for this webinar, we offered certain recommendations or suggestions to our chairman, Dr. N.H. Krishna sir. Sir was very clear, crystal clear in his thinking. He said, the topic for World Health Day should be a topic which caters to the maximum number of physicians. And the topic is going to be basics of chest radiography. He said, definitely, you have given suggestions, but this is decided. And I felt that is so accurate because chest X-ray is definitely the most ordered investigation in a chest physician's practice, perhaps in any physician's practice. So a very appropriate topic. I welcome you all to today's webinar. And the speaker for today's webinar is Dr. Nikhil Gupta, consultant radiologist at SPS Hospitals, Ludhiana. Dr. Nikhil did his MD from PGI Chandigarh and is a member of the European Society for Cardiovascular Imaging. I welcome Dr. Nikhil. And without further ado, let us start today's masterclass on chest radiography, back to basics.
Good evening, everyone. First of all, I would like to thank Dr. Krishna and CCI family for giving me this wonderful opportunity to be here today. I am Dr. Nikhil Gupta, consultant radio diagnosis and imaging, SPS Hospitals, Ludhiana. And today we will be discussing about back to basics in chest radiography. So let's begin. Chest radiography is the most common imaging modality. It is simple, inexpensive, and it gives a clue to the next appropriate test or the diagnosis itself. It is simple to interpret, yet complicated in so many ways. Let's begin. First of all, coming to conventional chest radiography, it is obtained by using 60 to 80 kilovolt, and it is the standard and most commonly used technique. It gives a higher contrast. This technique is known as low kilovolt technique. Coming to high kilovolt technique, it is obtained with 120 to 150 kilovolt, has a lower contrast, a grid or air gap is necessary to reduce scatter, and there is a reduction in exposure time, also reduction in radiation dose. However, it is obsolete with digital radiography. Now coming to the standard views. The standard views on a chest radiograph are PA view, AP view, and lateral view. Additional views being decubitus view, oblique view, lordotic view, apical view, expiratory film, and paired inspiratory and expiratory films. Coming to PA or postero-anterior view. Here the patient is facing the cassette and chin is elevated and centered on the top of cassette. Hands are placed over hips posteriorly and shoulders are forward, with X-ray beam centered on D5 vertebra, and superior border of cassette is 2 inches above the shoulder. Opposite to it is AP view, in which patient is supine or standing or semi-erect. It is done in very sick patients like those in ICU, patients, infants, or one who is unable to sit or stand. The direction of X-ray beam is anterior to posterior and at a distance of 100 centimeter, that is around 4 feet or less. A greater magnification of the heart is seen in this view, and the images are less sharp. It is obtained with back against the cassette and shoulders downwards and forwards. Back of the hands below the hips and elbow well forward. AP view can be obtained in supine position as well, where the cassette is positioned under the patient's chest with upper edge of the cassette above the lung apices. The arms are rotated laterally and supported by the side of the trunk. The head is supported on a pillow with chin slightly raised. Coming to the differences between PA versus AP view. In PA view, the clavicles project over the lung fields. The scapulae are away from the lung fields. No cardiac magnification is seen, and the vertebral spines are seen. In contrast to AP views, where clavicles are above the lung fields, scapula are overlying the lung fields, and there is cardiac magnification. Also, vertebral bodies are seen in this view. Supine AP versus erect AP chest x-rays. In erect AP, lungs are more expanded, air fluid levels are seen, gradient in the vessel size is seen, better positioning and control over respiration. Stomach bubble is seen below the left diaphragm. In supine, the diaphragm is elevated, prominence of upper lobe vessels is seen, pleural fluid will layer against the posterior chest wall, air fluid levels will not be seen, and it is difficult to see a small pneumothorax. In lateral view, the side of interest is in contact with the cassette, arms are raised above the head, the mid-axillary line is coincident with the middle of the film, cassette is adjusted to include the apices and the lower lobes to the level of L1 vertebra, central ray at right angle to the middle of the cassette at the mid-axillary line. So what are the uses of lateral chest X-ray? To check whether an equivocal chest X-ray shadow is actually present, to locate an abnormality seen on frontal X-ray, and to check the hidden areas, that is apices superimposed over the heart and the area behind the diaphragm. The lateral decubitus view is used to assess the volume of pleural fusion, mobile or loculated diffusion, small quantities of fluid, that is up from 50 to 100 ml, and to differentiate between subpulmonic and high effusion. However, it is now been replaced largely by the ultrasound and CT scans. In this, the side of the interest should be touching the table and X-rays are passed tangentially. Coming to oblique view, here the patient is turned 60 degrees away from the cassette. The side of interest is further from the film and centered at D6 vertebral body, and it is used to demonstrate mediastinum or ribs. Lordotic view, it is acquired in sitting position facing the cassette. It is at 30 to 40 degree with dorsiflexion at the waist, and it is used to demonstrate the mediastinum or ribs. Coming to apical view epigogram, it is used to see the lung apices, and in PA position, it is 30 degree caudal angulation and centering at D7 vertebral body. The quality of the X-ray film can be determined by the following methods. This first is centering. The medial ends of the clavicle should be equidistant from the spinous processes as seen in this image. In a rotated film, the side which is away from the film appears to be enlarged and hypodense, while the other side is partially obscured by the spine and more dense, as seen in this image. This is more dense and near to the film, and this is away from the film. So a thoracic scoliosis, as seen in this image, can also produce similar artifacts. Next is the penetration. The vertebral bodies and disc spaces should be just visible to D8-9 level through the cardiac shadow. In an overexposed film, there is reduced visibility of the lung parenchyma, and it masks the vascular and interstitial changes. Pneumothorax becomes harder to detect. In underexposed film, it enhances the visibility of normal lung markings and it is wrongly interpreted as pulmonary fibrosis or edema, and it obscures the central area, mediastinum, highland spine. Inspiratory film, the respiration must be fully suspended in deep inspiration, preferably at total lung capacity. Anterior 6 and posterior 10 ribs should be visible, as seen in this image. These are the anterior ribs and these are the posterior ribs, as seen by the arrows. Coming to the expiratory film, it is an important film. The heart will swing up to a more horizontal level and appear enlarged. The lung vessels will be less well inflated. Crowding of vascular markings will be there, which will simulate pathology or obscure lesions. Underinflammation of the lower lobe causes diversion of blood to the upper lobe vessels and mimic heart failure. Its use alone or with inspiratory film is to detect pneumothorax, diaphragmatic movement, foreign body, or air trapping. As seen here, this is an expiratory X-ray, and this is the inspiratory X-ray, which was later found to be absolutely normal. These are false opacities, as seen here. Coming to the interpretation of chest X-ray. First two things before we start are history and a previous radiograph for comparison. Then we interpret. First we look at the situs. Then we go by the acronym A, B, C, D, E, F, G, H, I. A is for airway, B is for bones, C is for corner of the film, D is for diaphragm and CP angles, E is for the edge of the arch, F is for the fields of lung, G is for gastric bubble, H is for hilum of lung, hidden areas, and I is for instrumentation. Coming to trachea, it is midline or just to the right of the midline. Maximum coronal and sagittal diameters on plate radiography are 21 and 23 mm for women and 25 and 27 mm for men. The trachea divides into two mainstem bronchi at carina, which is at D4 level approximately, and the right mainstem bronchus is shorter, steeper, and wider. In this X-ray, we can see narrowing and displacement of the tracheal shadow due to intraluminal lesion. The normal carinal angle should be less than 90 degrees, 60 to 75 degrees. Coming to cardiac borders. The cardiac borders are formed by the right paratracheal stripe or great vessels, superior vena cava, azygous arch, then again superior vena cava, right atrium, and inferior vena cava. The left cardiac border is formed by the left paratracheal stripe or great vessels, then arch of aorta, main pulmonary artery, auricle of the left atrium, left ventricle, and the paracardiac fat part. This is better shown here in this colored image. Coming to the heart borders in lateral chest X-ray, anteriorly there is right ventricle. Posteriorly, immediately behind the hyla, it is left atrium, and below the hyla is the left ventricle. And now coming to common devices on chest X-ray. Central venous catheter is central to the venous walls at the origin of the superior vena cava. So it lies just to the right of midline at the level of first intercostal space. It can be seen here. Also, we can see left-sided venous catheter from this end of the X-ray going to the origin of the superior vena cava. Then coming to endotracheal tube. The endotracheal tip should be ideally in the mid trachea, that is 4 to 7 centimeter above the carina. If the carina is not visible, it should be assumed at the level of D4, D5 interspace. Coming to chest tube. Proper placement of tip and side hole can be seen on a chest X-ray, as seen here. The eye or side hole can be seen as interruption of the radio opaque line, as seen here. This is one eye, this is the second eye. So this should be inside the pleural space, not outside. Otherwise, subcutaneous emphysema or pneumomediastinum may occur. Coming to cardiac walls. The prosthetic cardiac walls, these are the relative positions of prosthetic cardiac walls in a chest X-ray. So on the left side, there is mitral valve and pulmonary valve. On the right side, there is aortic valve and tricuspid valve. If in a lateral chest X-ray from carina to CP angle, we draw a line. The valve which lies anterior to this line is aortic valve, and which lies posterior to this line is mitral valve. Coming to cardiothoracic ratio, it is the maximum transverse diameter of heart with maximum width of the thorax. The normal transverse cardiac diameter is less than 14.5 centimeter for females and less than 15.5 centimeter for males. In adults, the normal cardiothoracic ratio is less than 0.5, and in children it is greater, that is up to 0.6. Coming to right atrial enlargement. The right heart border becomes prominent in practice. Identifying the enlargement of this chamber is very difficult, and this is seen the distance from midline to the right border of heart should be less than 5.5 centimeter. If it is more than 5.5 centimeter, then it is right atrial enlargement. In left atrial enlargement, the distance between the mid-inferior border of the left mainstem bronchus to the right lateral border of the left atrial density is less than 7 centimeter in normal patient and more than 7 centimeter in left atrial enlargement. Also, there is a left atrial appendage bulge and double shadow is seen through the heart. On lateral chest X-ray, there is a walking man sign in lateral view. Gross enlargement can displace and separate the left and right main stem bronchi, so that carinal angle widens and exceeds 100 degree. So this is wide open like a man walking. The normal angle does not exceed more than 100 degrees. LV enlargement. The Hoffman-Rigler sign for LV enlargement exists when the LV extends more than 1.8 centimeter posterior to the posterior border of IVC at a level of 2 centimeters cephalad to the intersection of LV and IVC. The prominent inferior aspect of the left heart border, as seen in these images. Coming to right ventricular enlargement, RV fills too much of retrosternal clear space. So this is the retrosternal clear space. It is obliterated in the RV enlargement. Next, coming to the mediastinum. Mediastinum is divided into superior and inferior compartments by imaginary line traversing the manubriosternal joint and the lower surface of the D4 vertebra. Inferior compartment has three parts: anterior, middle, and posterior. The borders of anterior mediastinum are anteriorly the posterior border of sternum, posteriorly a line drawn from anterior aspect of trachea and posterior margin of the heart. The middle mediastinum, the anterior Anteriorly, this is the posterior margin of the anterior mediastinum, and posteriorly it is a vertical line drawn among the thoracic vertebrae 1 centimeter behind the anterior margins. And this is the this line marks the anterior boundary of the posterior mediastinum, which goes posteriorly up to the costovertebral junctions. The contents of mediastinum are in anterior compartment, mainly fat, lymph nodes, thymus, thymic remnant, heart, ascending aorta. In middle mediastinum, trachea, bronchi, lymph nodes, esophagus, and descending aorta. And in posterior mediastinum, paravertebral soft tissues can be seen. Coming to anterior junctional line. It is the anterior apposition of the lungs. It is 4 layers of pleura separating the lungs behind upper 2/3 of the sternum. Runs oblique from upper right to left lower, as seen here. Does not extend above the menobriosternal junction. And the anterior mediastinal masses can obliterate the anterior junctional lines but preserves the posterior junctional line. Right paratracheal stripe. It is seen projecting through the SVC as seen by these arrows, formed by the tracheal wall, mediastinal connective tissue, and paratracheal pleura. It is visible due to air soft tissue interface on either side. So as we can see here, air, soft tissue, air. More than 5 mm width is considered widened. Then coming to the widening of the right paratracheal stripe. The mediastinal it may be due to mediastinal lymphadenopathy as seen here, tracheal malignancy, or mediastinal tumor, or mediastinitis, or even encysted pleural effusion. Right-sided aortic arch is seen in 0.5% of population, and it may obliterate the right paratracheal stripe as seen in this image. The absence of aortic knuckle on the left should help identify this variant. So we don't see a aortic knuckle on the left side as in this X-ray. Coming to AP window reflection or AP window. It is bounded by the aortic arch superiorly and the pulmonary artery inferiorly. AP window reflection extends from aortic knob to the left pulmonary artery and has a normal concave appearance as seen here. So if there is a convex border on AP window, it is considered abnormal. It can be due to aortic arch aneurysm or lymphadenopathy. Coming to azygoesophageal recess, the interface between the right lung and mediastinal reflection inferior to the arch of azygous vein, with the esophagus lying anteriorly and azygous vein lying posteriorly. This is the esophagus, this is the azygous vein. This is the azygoesophageal recess. So on a chest X-ray, it runs from diaphragm on left of midline up to the right, extending to the tracheobronchial angle. See, from left to right superiorly. Upper few centimeters is always straight or concave as seen here towards the lung, like an inverted hockey stick. Coming to the abnormality of the azygoesophageal recess, a convex shape of upper end suggests the presence of subcarinal mass or left atrial enlargement, more inferior to the subcarinal region. Esophageal disease or hiatus hernia can be detected here. Then coming to the posterior junctional line, which is normally 2 mm normal dimension. It is the apposition of lungs posterior to the esophagus and anterior to the vertebral body D3 to D5. seen here, seen above the suprasternal notch and lies vertical, whereas the anterior junction line deviates to the left. The prevertebral disease superior to the level of aortic arch may obliterate the posterior junctional line. Coming to paraspinal lines. This is the interface between the lung and pleural reflection over the vertebral bodies. The left paraspinal line is more commonly seen than the right. So here we can see the left paraspinal line. It is wider due to descending aorta. Left paraspinal line is less than 10 mm and it runs parallel to the lateral margin of the vertebral bodies and can lie anywhere between medial to lateral wall of the descending aorta, as seen in this image. And right paraspinal line is less than 3 mm and lies within a few millimeters of the vertebra, as seen here. So it is disrupted by paravertebral diseases and neurogenic tumors. Enlargement occurs with osteophytes, tortuous aorta, paravertebral hematoma, vertebral masses, and dilated azygous system. Coming to diaphragm. The right diaphragm is usually 1.5 to 2.5 centimeter higher than that of the left. More than 3 centimeter distance is abnormal and borders should be sharp. We should look for gastric bubble, air under the diaphragm, and pleural effusion. Coming to diaphragmatic flattening. The highest point on the hemidiaphragm should be 1.5 centimeter above a line drawn from the cardiophrenic to costophrenic angle normal. Here we can see flattening of the diaphragm due to overinflated lungs. Coming to CP angles. Normal CP angles are acute and sharply defined, as seen here and here. CP angles may contain low density, ill-defined opacity, which contain fat pad, right here and here. Pleural effusion. On erect X-ray, it is opaque meniscus at a costophrenic angle and requires around 200 to 300 ml of fluid. If very large opacity is there, it is seen with contralateral mediastinal shift. Then coming to supine. On supine chest X-ray, the pleural fluid layers out in posterior part of the pleural space and hemithorax appears wider than the normal side, and normal lung vessels can be seen through this shadowing. Approximately 200 ml of fluid is required to detect in the supine X-ray. Other patterns are lamellar, where the shadow appears parallel to the lateral aspect of lung encysted, localization within a fissure or somewhere else, and subpulmonary, where the pooling occurs below the lung. Relatively common and easier to detect on the left side because here we can see the gastric bubble appears widely separated from the superior margin of the diaphragm. So, and the normal distance between dome of diaphragm and air in stomach does not normally exceed more than 7 mm. So, if this distance is more than 7 mm, subpulmonic infusion should be thought about. Coming to pneumothorax. On erect X-ray, 3 cardinal features are there. A clearly defined line visible parallels the chest wall, as seen here. The upper part of the line is curved at the lung apex and also keep looking between the ribs, as seen in this image. This is a small pneumothorax. Coming to erect, an absence of lung markings between the lung edge and chest wall is confirmatory. 3 tricks if in doubt. Erect X-ray in full expiration, lung density increases on expiration. So we do expiratory scan. In a lateral decubitus with suspected side up, the intrapleural air will rise and outline the pleura around the lateral margin. And however, CT is ultra sensitive test. On supine, pneumothorax can be very subtle. So firstly, we go for the lung base inspection. A hyperlucent upper quadrant of the abdomen, air collecting at the base of the lung overlies the liver. Second, the air situated in the lateral costophrenic sulcus, the most lateral and inferior aspect of the pleural space, the so-called deep sulcus sign appears, and a sharply outlined dome of diaphragm, particularly prominent if there is adjacent lower pulmonary disease. So here we can see prominent left dome of diaphragm. Here we can see air over the right dome of diaphragm, air over the left dome of diaphragm, and here it is the lateral costophrenic sulcus. A deep and well-defined, on medial inspection, a deep and well-defined anterior costophrenic sulcus may be the earliest sign of a small pneumothorax. A sharply defined cardiac border, a sharply defined pericardiac fat pad as seen in this image, and a sharply defined margin of the anterior junctional line. Coming to tension pneumothorax, which is a medical emergency. It can cause compression of IVC and obstruction of the venous return to the right side of heart. It is potentially and rapidly lethal. Two cardinal features to look for. The ipsilateral dome of diaphragm is nearly always depressed and attenuated, and the mediastinum and heart are usually, but not always, pushed to the opposite side. So these are the cardinal points to be looked on erect or a supine chest X-ray. But sometimes on supine chest X-ray, it is difficult in a diseased lung. So, however, the dome of diaphragm will nearly always be flattened or inverted by the raised intrapleural pressure. So the action to be taken is an urgent placement of the cannula in the pleural cavity. Here we can see flattening of diaphragm and contralateral shift. This is an image of a hydropneumothorax with air fluid. Coming to lung fields, the lungs are divided into upper, middle, and lower zones, as seen here, by the anterior, by the first two ribs, then second, then third and fourth, and so on. Then coming to the lobes. The right lung is divided into upper, middle, and lower lobes by horizontal and oblique fissures, and the left lung is divided into upper and lower lobes by the oblique fissure. The main fissures are oblique fissures, which are major fissures, and horizontal fissures, which are minor fissures. Accessory fissures being azygous, superior accessory, inferior accessory, and left-sided horizontal fissures. The horizontal fissure runs from the hilum to sixth rib in the axillary line. The major fissure from D4 to D5 through the hilum and to near anterior the cardiophrenic angle. The left is 5 centimeter behind the anterior CP angle, and right is just behind the CP angle. Here. This is right, this is left. So these are the lobes. This is the right lobe on anterior, and this is on the lateral, right upper lobe. This is the right middle lobe, seen on lateral. This is anterior, and this is the right lower lobe, as seen here. On the left side, this is the left lower lobe. This is left upper lobe with lingula, and this is the upper division, that is without the lingula. Coming to azygous lobe fissure. It is seen in 1% of population, contains azygous vein at its lower end. It is seen in this image. And failure of normal migration of azygous vein and persistent of invaginated visceral and parietal pleura. The azygous lobe is smaller and therefore less transradiant than corresponding normal lung. Superior accessory fissure. It separates apical from basal segments of lower lobes. Inferior accessory fissure separates oblique. It is an oblique line running from cardiophrenic angle to hilum and separates medial basal and anterior basal segments. Left-sided horizontal fissure. It is similar to right-sided one, separates lingula from the upper lobe. Coming to the vasculature. The pulmonary blood vessels are responsible for branching linear markings within the lungs. They gradually taper in the periphery. In erect film, the upper zone vessels are smaller than the lower zone vessels, but this gradient is not seen in the supine films. The maximum diameter of this descending branch of the pulmonary artery is 16 mm here in the males and 15 mm in the females. The upper lobe veins lie lateral to the arteries at the first intercostal space. The normal vessel should not exceed 3 mm in diameter. The azygous vein dilatation more than 6 mm on upright PA radiograph or more than 1 centimeter on supine radiograph. Few rules are there. Azygotracheal. The azygous vein, if visualized at the right tracheobronchial angle, should be no wider than approximately 1/2 the width of trachea. The tracheal diameter should be equal on PA and lateral views and should be less than the width of vertebral body. The right lower lobe to trachea. The right lower lobe pulmonary artery should not be wider than width of tracheal lumen. Arteriobronchial, an artery and its accompanying bronchus should be of the same size. The lymphatics run in the interlobular septa, connecting the subpleural lymphatics and draining via the deep lymphatics to the hilum. Normal lymphatics are not seen, but thickening of the lymphatics and surrounding collective tissue produces curly lines. Coming to the hilum, it contains bronchi, pulmonary and systemic arteries and veins and lymphatics, lymph nodes and autonomic nerves. Only pulmonary arteries and upper lobe veins contribute significantly to the hilar shadow on plain radiographs, should be concave laterally and of equal density and similar size on either sides. The left hilum is higher than right in 97% of patients and at the same level in 3%. The left pulmonary artery lies above the left main bronchus before passing posteriorly, whereas the right side artery is anterior to the bronchus, resulting in the right hilum being lower. Hilar point, the arrows indicate the hilar point where the superior pulmonary vein crosses the descending lobe artery. The left normally being at the higher level than the right. Coming to the enlarged hilum. Causes of enlarged hilum are lymph nodes that may be due to TB, sarcoidosis, malignancy, mediastinal mass lymphoma, enlarged vessel, pulmonary hypertension or pulmonary artery aneurysm. A rhomboid fossa is irregular notch at the site of attachment of costoclavicular ligament. It lies 3 centimeters from the medial end of the clavicle inferiorly and has a corticated margin. So it should not be mistaken for a destructive lesion. Coming to extrapulmonary tissues, we should look for supraclavicular fossae, lateral chest wall for surgical emphysema, and under the diaphragm for pneumoperitone. Coming to other soft tissues, nipple shadows are well defined laterally and may have a lucent halo. And if need be, we should repeat the x-rays with nipple markers. Skin folds are seen running vertically, can be confused with a pneumothorax. Skin fold, if followed, usually extends outside the lung field. Coming to companion shadows, these are soft tissue adjacent to bony structures, 2 to 3 mm thick. seen running parallel to upper border of the clavicle and inferior borders of lower ribs. Then coming to ribs, superior rib notching is caused by abnormal osteoblastic activity, as in osteogenesis imperfecta or any connective tissue disorder, or abnormal osteoclastic activity that may be in hyperparathyroidism, or miscellaneous in NF1, restrictive lung disease, polio, progeria, and abnormal muscle pull. Inferior rib notching is generally vascular, so it may be coarctation of aorta or interrupted arch or subclavian artery obstruction, or AVM or TOF, or maybe due to neurogenic tumors or NF1. Superior and inferior notching are due to hyperparathyroidism and NF type 1. Coming to the lateral film. Here we can see first is the sternum, the body of sternum and the manubrium. Then we can see retrosternal clear space. Then we can see retrosternal stripe. This is the retrosternal clear space. This is the retrosternal stripe. This is the heart. This is the retrotracheal triangle. Then coming to the vertebral translucency. Then retrocardiac clear space. And the diaphragm. And the rest is the lungs and the fissures. How to differentiate between left lateral and right lateral film. The leaf of the diaphragm is seen best through the heart. On right lateral, it is the right. On left lateral, it is the left. The higher leaf anterior and posterior is in the right lateral is right, and in the left lateral is left. In obliteration of the segment of right leaf by IVC is seen in the left lateral. Dense caval triangle is seen more on the left lateral. Arch of posterior leaf is flatter. Left arch is flatter on right lateral, and right arch is flatter on the left lateral. The sharper leaf in right lateral is right, and left lateral is left. And we can identify the right major fissure in right and left major fissure in left. Coming to the retrosternal clear space, it is the normal lucency posterior to the sternum, and normally around 3 centimeter. It is increased in emphysema, decreased in RV enlargement, and main pulmonary artery dilatation and anterior mediastinal mass, as seen here. This is the retrosternal clear space. It is increased in the emphysema. Here it is obliterated in a thymoma and increased in a emphysema. Coming to retrosternal line, it is interface between retrosternal soft tissue and the anterior aspect of the right lung. Includes retrosternal fat, internal memory nodes, and vessels, as seen here. If there is a bulge in retrosternal line, it is abnormal, as seen in this patient. There was a hematoma. The vertebral bodies become translucent caudally, and there is less soft tissue and no scapula overlying the lower vertebrae. However, if we see this loss of translucency, this is known as spine sign, and it is pathological. The diaphragm, the right diaphragm is visualized till the anterior chest wall. Anterior part of the diaphragm merges with the cardiac shadow. The dome nearer to the film is higher and less magnified. Coming to the hidden areas. Hidden areas are the apices, the hyla, the retrocardiac area, the retrodiaphragmatic area, and the parts obscured by bones. In this image, we can see mass is obscured by the ribs and clavicle here. First rib and clavicle. Coming to the classical signs in chest radiograph. Hilum overlay sign. If the hilar structures are clearly seen through the mass, it is either anterior. The mass is either anterior or posterior to the hilum, as in thymoma, mediastinal, anterior mediastinal mass, and descending aorta aneurysm. Hilum convergence sign. If vessels converge on hilar opacity enlarged, if vessels converge on hilar opacities, the pulmonary artery is enlarged. If vessels goes through the opacity, there is a nodule or mass. Silhouette sign. This is loss of normal interface when two areas of similar densities come in contact with each other. If the right middle lobe is silhouetted, then if the right cardiac border is silhouetted, the mass is in the right middle lobe. If the left cardiac border is not seen, the mass is in the lingula. If aortic knuckle is not seen, then it is in the mass is in the apico-posterior segment of left upper lobe. And if the right aortic border is obscured, then anterior segment of right upper lobe and middle lobe of right lung is involved. If hemidiaphragms are involved, the ipsilateral basal segments are involved. Coming to cervicothoracic sign, if the lateral margin of a mass is extending above the level of clavicle and is well defined, it is a posterior mediastinal mass. Thoracoabdominal sign, sharply marginated mediastinal mass seen through the diaphragm must lie in the thorax in posterior location. Convergence of lateral margin towards the spine indicates thoracic mass. Air bronchogram. Visualization of branching linear lucences within opacities, within an opacity represents air-filled bronchi. So this is an indicator of a consolidation. Thank you for your patient listening.
Thank you for such an elaborate and yet comprehensive talk on chest radiology, radiography, Dr. Nikhil. While you covered so much in depth, we still have a lot of questions because the questions are lining up. But let us walk through the chest radiology, radiography step by step while we unfold the questions and take the talk forward. So we talked about how so many types of pneumonias can be checked on, can be picked up on chest X-ray. And we talked about the silhouette sign. So Ben Felsen, the famous American radiologist, he gave the silhouette sign. And I'm sure every chest physician, and I believe also every radiologist, would have a copy of the Felsen's book of chest radiography. So I would like you to start the Q&A with an elaboration of the silhouette sign.
Good evening, everyone. Good evening, Dr. Keerat. Thank you for such kind words. And thank you for the question. Silhouette sign is like the loss of interface when two similar densities come in contact with each other. So the consolidation, like a consolidation or a mass which has similar density to the mediastinum or soft tissues of the abdomen. So they form this silhouette sign. For example, there is a mass in the basal segments, or there is a consolidation in the basal segment, and the hemidiaphragms are hidden. So we can be conclusive that there is something wrong in the basal segments. Or if, for example, there is the right aortic border cannot be seen. So we can be sure, we can be suspicious, right? About the interior segment of the right upper lobe and the middle lobe of right lung. If the aortic knuckle is not visible, then we should suspect a pathology in apicoposterior segment. If left or right cardiac borders are not seen, then lingula and the right middle lobe should be suspected upon.
Right. So, very well said. And this is what we do generally come across the Sillet sign, very commonly seen when we have a suspicious, we use the terms paracardiac density seen or homogeneous opacity. Let me ask you, are there any conditions where the finding on chest X-ray looks like the Sillet sign, but is not actually the Sillet sign? What are the mimics of Sillet sign on chest X-ray?
For example, fat is the greatest mimicker. Pericardial fat or below subdiaphragmatic fat or above diaphragmatic fat. It is the biggest mimicker of silhouette sign. Also, azygous lobe fissure can mimic. Also, like sternal abnormalities or
like depressed sternum that can also lead to the looking like a silhouette sign.
And some AP views can be in such a difficult position that they can obscure the lung borders or
yes. So that's a very valid point. That's why I personally ask, and you believe me, still, despite my persistent orders to follow in the ICU that the chest X-ray should be done in a propped up, upright position, not with the patient at 45 degrees. So often, I will still come across patients where the X-ray has been taken and the patient was supine. So this happens. This is how things streamline over time. Coming to a more clinical question, this is a question that I've gotten from Miss Bijal, Dr. Bijal. So she's from Assam, she's asking that a patient came to the OPD after being in the ICU for 2 weeks with community-acquired pneumonia. And at 2-week follow-up in the OPD, the patient still has not got a clear chest X-ray, but is doing clinically well. Should she go in for a HRCT test?
There is a rule for such kind of patients. The 6-week rule, you might have heard about it, that we follow up after 6 weeks. If it is a pneumonia, it should have been resolved. If it is a malignancy, it will definitely change. Maybe it grows in size, calcification develops, or something else happens. Hemorrhage happens in it. So a 6-week rule is applied. However, nowadays, with the advancement of low dose HRCT, there is no harm in doing a CT. It can also be.
Yeah, I think it's a very valid question. We commonly come across such cases in the OPD when the patients come back on follow-up. And important point that Bijal has actually given us is that the patient is clinically doing okay. She feels the patient is clinically doing okay. So if I believe the patient is not a smoker or is not diabetic or at high risk for any uncontrolled infection or high risk for malignancy, she may take the time, ask the patient to come on follow-up and get a repeat chest X-ray till 6 weeks, follow up the patient for another 4 weeks. Or she could go in for, as you added, a low-dose HRCT. That's another thing that, yes, we could think of. It's a good tool at our disposal. So the next I would like to ask you is, we commonly read, see written in the chest X-ray reports, and also we use these terms that, oh, there's a consolidation, or there's a collapse, or there's a collapse consolidation. So I want you to particularly talk about these terms, when to use the term consolidation and when to use the term collapse.
See the
And when
collapse.
could we use collapse consolidation?
Yeah, both of them can coexist actually in ICU setting mainly, because see, in pleural effusion there is basal collapse or basal consolidation. So in those cases, but collapse is generally frank collapse is generally there are signs for it, like there is volume loss in collapse. There will be the ribs will come, they will come together as compared to other side, and also there are other signs of collapse
Tracheal
like
shift would be there, pulled, or mediastinal shift
mediastinal shift.
as well, right?
Yeah, mediastinal shift, and consolidation will have air bronchograms.
Right.
Also, raised hemidiaphragm can also be
Right.
there.
So, can there be any situations, any conditions where we have mimics of collapse, but it's not actually there? There's no collapse.
One of the things we have already talked about is azygous fissure. So that is, we should be able to identify it. The second may be unfolding of vessels in the elderly that can mimic a consolidation or a collapse. Depressed sternum, as we uh, discussed a little while ago, and fat, greatest mimicker of everything.
I hope
And
I will not take it personally when you are referring to fat over and over again, Dr. Nikhil.
yeah, it is pericardial, epicardial fat. That is what I'm referring to, or subdiaphragmatic, supradiaphragmatic fat.
Thank you. So,
And
I like how you refer to, please carry on.
hiatus hernias, basically hiatus hernias.
All right. So, I really like how you refer to not missing out on the azygous fissure. And this reminds me that my great, revered, beloved teacher, Dr. B.C. Sareen, Bipin Chandra Sareen, he used to, whenever he would show us an X-ray, in an X-ray which would look so innocently normal, we would always look for cervical rib and azygous fissure. Because if sir is showing us a normal X-ray, it cannot be a normal X-ray. There is something which we are missing out, and I see what the mind knows. So that's how he trained us. So I really like how you're referring back and forth to the azygous fissure, and yes, that's a very important point. Thank you for that.
Also, I would like to add the clavicles are very important. Sometimes both the clavicles are not seen, as in cleidocranial dysplasia. So it is symmetrical, so it looks like a normal X-ray.
Right, that's true. That makes sense. And thank you for that. So my next question to you is that when we see a X-ray in the normal practice, we might feel that the hyla is looking prominent. So we're suspicious. So many times we might go in for a HRCT test because we think it is prominent and it may or may not come out to be anything on the HRCT. I want you to elaborate on when do we look at a prominent hyla and say it's actually an enlargement of the hyla, and hilar enlargement.
Hilar enlargement is a difficult topic. So first of all, there are two hila. Left is generally higher, and right is generally lower. So if it changes, like right becomes higher, so it is abnormal. The density of both the hila are not equal. It is suspicious. Also, the pulmonary vein can be seen, which is almost of the diameter of the little finger. So it is called a little finger sign. So if anything outside of it is seen, so it is also suspicious. Then yeah, that's much about it. Also, we see in the AP window, if there is a convexity in the AP window, we can see, and the paratracheal stripes, widening of the paratracheal stripes.
All right. Thank you for that. So we have some questions coming in. So, and we have some additions as well. Dr. Deepak Bhanushali from Maharashtra, from Yavatmal says, can you read out a normal chest X-ray and its findings? So, Dr. Deepak, we've just gone through the detailed uh, signs which have been elaborated, and we'll keep talking back and forth about the findings of the normal chest X-ray, like we just talked about, not to be missed, cervical ribs, not to be missed, ascites fissures, how to look at the hila, which is looking normal, but maybe actually be enlarged. So yes, we'll go about it. And yes, it is correct. It is the crowding of ribs that we will see when there is lung prolapse. And then we have a question from Dr. Ayush Vishwakarma. He's also from Yavatmal, Maharashtra. Are you guys watching this webinar together, sitting together? I would love to hear your response to that. So he's asking, kindly elaborate how to differentiate the zones of lungs. Could you answer that for him?
The zones of the lungs are differentiated by the number of ribs. Easiest way to do it is anterior two ribs. Anterior first two ribs is upper zone, then outside of third, fourth, outside of fourth rib is lower zone, and between second and fourth rib is mid zone. That's how we do it in a full inspiration chest X-ray.
Full inspiration. That's a point not to be missed. So, taking up the next question, how do you? Okay, so this is also before the next question is actually, how do you approach and read further into a whiteout lung on chest X-ray?
Whiteout lung. Yeah. So whiteout lung means a large pathology, mainly. It may be the first thing that comes to our mind is pleural effusion. A massive pleural effusion with contralateral mediastinal shift.
Right.
Right. Then we come to, if it is ipsilateral mediastinal shift, then it could be a collapse or a consolidation. But in consolidation, there will be no shift, or a mild mediastinal contralateral shift. And the third thing is pneumonectomy. Their ribs will also be missing.
Good catch. So let me share a case. There, I saw this patient with massive whiteout lungs bilaterally, trachea, mediastinum central, no shift, nothing to suggest pleural effusion on the lung ultrasound. So this actually was a case. This patient was a goldsmith, and he was working with the fumes. And he happened to be working. He was a young guy. He happened to be working with the room closed. So those fumes, they called such massive ARDS. It actually looked like a whiteout. So thank you for that answer. Here's an input from our very beloved Dr. Tridip Chatterjee from Maharashtra, from Mumbai. Sir is saying, before checking hilar enlargement, always check rotation of film. Thank you, sir. Thank you. This is a very important point indeed. And every postgraduates and every practicing physicians, I think we need to remind ourselves over and over again when we see the chest X-ray, is the exposure right? Is the rotation right? So we need to see the centering. And so these are the points which are not to be missed. We have to start from the basics, and hence the webinar that has been chosen for today, Back to Basics. So I would like to ask you that in the ICU, we commonly see basal shadowing on the chest X-ray. How do you think we should approach such an X-ray?
Basal shadow. Okay.
It could be fusion, it could be consolidation. How do we go about it clinically and practically?
First of all, if it is basal and consolidation or collapse, first we should look for is CP angles, rotation CP angles. If CP angles are blunted or are not seen properly, generally we don't see them properly in AP views. So we go for the next best investigation is a bedside ultrasound. We can rule out fluid in that. Or else CT is always the problem solving tool. Or we can use a lateral decubitus position. And yeah, that's it.
Yeah. So that makes sense. That's about it. So differentiating between the basal shadows, whether it is consolidation or whether it is, pleural effusion. Yes, we can use ultrasound, which is becoming more and more used tool in today's ICUs. Also, I would like to add here that clinically we look at the patient, whether there's evidence of fluid overload and whether there's pulmonary signs of any other signs of pulmonary edema. And so, yeah, that's about it. Thank you. I would like to now move on to pleura and ask you a very practical question. What is the difference between pleural plaques and pleural calcification?
Pleural plaques are generally thickening of the pleura, generally due to asbestosis, most commonly, and then it becomes calcified later on. However, pleural calcification can be due to other causes like hyperparathyroidism or effusion that has been calcified or hemorrhage that has been calcified, like that.
So a calcification is always like a chronic sequel.
Yeah.
To say pleural thickening or any other cause of, like, if say even a pleural plaque can undergo calcification, as you said.
Actually, pleural plaques also undergo calcification, so it is sometimes very difficult to differentiate.
Right. And so if we have a pleural lesion and we have an intrapulmonary lesion, how can we differentiate between the two lesions on a chest X-ray?
First thing is the angle with the pleura. If it is an acute angle with the pleura, the lesion is generally within the lung. If the angle is obtuse, it is generally, or as we say it, pleural based lesion that has obtuse angle with the pleura. That is one way to do it. Another is the lung lesion will be surrounded by lung on almost all sides.
Right.
Yeah.
Can you hear me?
Yes, I can hear you.
Yes. And how would you differentiate an intrapulmonary lesion from a rib lesion?
From a
Rib lesion.
rib lesion. So it will be very difficult to differentiate a pleural lesion from a rib lesion because both will be coming from outside to inside. Both will be making an obtuse angle, but we have to see the lung with it. Rib with it. There will be destruction of the rib or expansion of the rib. If that is there, so we can say it is a rib lesion.
would it help to take like a lateral view or an oblique view to differentiate the intrapleural, intrapulmonary, or rib lesion?
We can see the do like this is a maneuver we do. We turn the X-ray upside down and then we see it with the rib. It helps. And then we can take AP views to see the change in position or lateral views.
Right. So I think rib and intrapleural, in pleural and rib, if there's an overlap, it's more difficult to tell. But yeah, if it is to differentiate from the intrapulmonary, even the lateral view, it will help. So thank you for that. Coming to the next question, what are the alarm signs that one should always check for when we are seeing a chest X-ray?
Uh, I didn't get that. Sorry.
So what are the alarm signs? Like what are the things which if we miss on a chest X-ray and that would lead to say an emergency situation. So okay, this you should always check. Otherwise it's like dangerous.
Pneumothorax is the most dangerous, which can turn into tension pneumothorax in a very little time.
Right.
ARDS and foreign bodies.
Foreign bodies, right? So you just mentioned ARDS. Can there be an overlap of pneumothorax with ARDS?
There can be, both can coexist.
Yes. So I've had this experience of a patient who was on ventilator. And so the view, when the chest X-ray, like we could see that the lung markings are there on both sides, but it was actually subcutaneous edema, subcutaneous emphysema that the patient was developing on one side. On the X-ray, it was seen as like lung markings being present, and so that's why it was very important clinically. But the only giveaway was that there was a mediastinal shift, although it was very slight and early, and then it was picked up. So this happens because the patients who are in the ICU, a lot of times they are who are on the ventilator, they are lying down. A lot of times, even when we are seeing pleural effusion in such patients, it may not be seen as an effusion because it's just layered across the posterior wall of the thorax because the patient is lying down, patient is supine, and a patient who's on the ventilator is not actually made to sit propped up for the chest X-ray. So that also happens very commonly, and it can sometimes give the impression that the consolidation is worsening or interstitial pneumonia is worsening, but that's not the case. So again, attention to the position of the patient while the X-ray is done. And obviously the CT scan is much more helpful in differentiating when it comes to such conditions. So I would like to you to answer this question from Dr. C. Mohan Rao from Odisha, from Bhubaneswar. Good evening, Dr. Rao. So his question is, what are the reasons for bilateral volume loss in chest X-ray? I think most common would be an expiratory film.
Yeah.
And
atelectasis, bilateral basal atelectasis.
Right. ILD cases, perhaps. And again, bilateral, then we expect it to be symmetrical, right? Certain restrictive lung diseases. Most common, I would say, my vote would be again, most common would be expiratory film. All right. So we just talked about ARDS and pneumothorax, and I would like you to draw some special attention to the important signs of a developing tension pneumothorax. What are the important signs to, and also what are the important signs to pay attention to when you detect tension pneumothorax on a chest X-ray?
If a patient has tension pneumothorax, the two important signs are there. One is flattening of the diaphragm, and the other is mediastinal shift. But mediastinal shift may or may not be there. But flattening or inversion of diaphragm, however subtle it may be, is there.
Right.
The diseased lung is generally less elastic, so mediastinal shift develops late if it is in a diseased lung.
Right. And how would you say that this is a small pneumothorax, this is a large pneumothorax?
Depends on the size of the pneumothorax. Like 2 centimeter is the cutoff, I think.
Right.
Not sure, but yeah, I think 2 centimeter.
But nevertheless, any pneumothorax deserves it.
Yeah.
And what would be the mimics, pneumothorax mimics, conditions where it looks like there's a pneumothorax, but it's just a virtual finding. There's no real pneumothorax.
First is the artifacts or skin folds, clothing artifacts or skin folds. But the thing is, they are outside the field of outside the lung field, so they will be continuing into the abdomen or into the chest wall. So that can be differentiated like that, or a large bulla.
Right. I think that is the main differential. Mostly that is what we come across. And large bulla. And then there are some conditions where there is hyperinflated lung and they're like very emphysematous lung, but it looks like there's pneumothorax. One important point I want to talk about is that whenever we're checking the chest X-ray in a patient on a regular basis, we should always look at the apices, because the smaller pneumothoraces will be missed because it might be in the apex, and if you do not pay attention, it will be missed, and it will come about later on when the patient is obviously clinically debilitated. So next, I would like to talk about the mediastinum. What are the key features to detect or identify a mediastinal mass?
Mediastinal
Mass.
So there, these lines and stripes are the greatest help in doing so. Anterior junctional line, posterior junctional line are displaced. Tracheal stripes are displaced, or there is increased density of the mediastinum, and there is change in the contour of the mediastinum. Generally, that helps. We should see the cardiac borders very carefully if the mass is indenting on any cardiac border or something like that.
Right. So we will not go further into the differentials like pericardial effusion and etc., because I think you've talked about that in detail, and we have a lot more questions to cover. So coming to a very specific question, what is the March effect? The March effect.
The Mach effect is generally it is a artifact basically. The left border of the heart is darker in some cases. This is due to technical reasons. So it appears as a sharp black line. So a sharp black line like over the left heart border, so it can mimic pneumothorax on a AP view. So we do a lateral decubitus view to differentiate, or CT, generally CT can be done.
So I think the Mach effect can also be, it can be confused or it can be mistaken for pneumomediastinum. because there's air at the left cardiac border. It looks like there is air, but it's actually just a dark strip, right? And so coming to the next question, um, how to look for the missed lung cancers? As in, how would you look for specifically commonly missed out? How do we make sure we don't miss out signs of an early cancer? What are the common reasons for missing out findings of lung cancer on chest X-ray?
Mainly it is, I think, due to mass in the hidden areas of the lung, bilateral lung apices, behind the bones, and in the soft tissues, and below the diaphragm, in the cardiac shadow. So we should always double check these areas, and mainly below the ribs.
Right. So I'd like to take this question from Dr. Vishal Randhawa Arya from Meerut, Uttar Pradesh. Sir is is a very revered senior physician. So sir is asking how to differentiate chest X-ray. Basically, he's asking how to pick up miliary tuberculosis and ILD on chest X-ray. So sir is asking you two questions. And actually, I would like to, I would like to club this with another question. This another question is by Dr. Saibal Ghosh from West Bengal, Kolkata. And Dr. Saibal is asking how to pick up interstitial pathology earlier in chest X-ray. So ILD and interstitial pathology and then miliary tuberculosis. Just like a few pointers.
In miliary TB, there will be miliary shadows, like very small shadows. And in ILD, there is generally reticular opacities more towards the bases, generally, because ILD is seen with the apicobasal gradient. So
there would be different kinds of
UIP pneumonia.
UIP or
most common type.
Maybe fibrosis in the basal areas or in the upper areas, in the apical areas, depending on the type of ILD again. And a very interesting case I would like to discuss, a recent thing I found. There was this patient, it was a reference call I got. The patient was, they said, a CKD case of CKD and suspected meningitis. And so I saw the chest X-ray and I said, it looks like miliary tuberculosis. And suspicious for that. And the low basal area was anyway occluded, like it was covered with the pulmonary edema picture and with the fluid. And said it looks like miliary, and patient was quite sick. And the next day, the patient went for CT chest, and it was reported as pulmonary edema, frank edema, because there was such massive effusions they were there, and the edema was actually masking the miliary pattern underneath. And that's when we realized, and actually tuberculosis, it was miliary tuberculosis when the patient underwent dialysis. Two things to learn is that whenever you're planning HRCT for a patient, always plan it in a manner that it's after the dialysis has been done, so that obviously one can see more and more lung parenchyma. And similarly, when there is massive pleural effusion, always it's a better practice to drain the fluid and then going for a HRCT. So in this particular case, I felt that the chest X-ray outdid the HRCT test. So thank you for that. I would like to ask you a question on a very common finding. That is, we find apical thickening very commonly on chest X-rays. So many times we will just pass it off as normal or will not pay much attention to it. I want to ask you that what is the significance of picking up apical thickening on a chest X-ray?
Apical pleural thickening is generally most commonly seen in tuberculosis. And sometimes the apical cap of the uh, apical cap is normal. So it is less than 5 mm, I think, and it can obscure a mass in the hyla. I'm sorry, in the apex.
So there's a message from our beloved Dr. Krishna sir. He says he's congratulating you, Dr. Nikhil, on wonderful detailed masterclass. He's saying it's a wonderful treat, and compliments from Dr. Krishna. And sir is telling us that there are 966 logins as of at 9 p.m. There were 966 logins. Thank you everyone for joining us on World Health Day. And I'm so glad. I really hope you all enjoyed today's webinar. And we'll try to take a few more questions before we wrap up. I would like you to take up this approach to enlarge cardiac shadow. So we pick up a chest X-ray, we say that there is cardiomegaly. Now, how do we actually read further into this chest X-ray?
Cardiomegaly is generally due to chamber enlargement. One chamber can be enlarged, two can be enlarged, three can be enlarged, all four can be enlarged. Or pericardium can be enlarged, so pericardial effusion. And so if the left ventricle is enlarged, so there is prominent left heart border generally. And if the right ventricle is enlarged, the cardiac apex is elevated generally. That is what we look for.
I'd also like you to draw some attention to unfolding of aorta. Because this is something, how do you see a chest X-ray and say this is unfolding of aorta?
We follow the aorta generally. So it is like a walking cane from the apex of the heart going down. So when we follow it, we can see also there is calcification along the wall of aorta. So generally in older people, we see calcification of the aortic knuckle, and along with there is unfolding of aorta. So we can see a straight line going from the aortic knuckle. So it is unfolding of aorta.
Thank you. And I would like to ask you another question. Again, I think with my special interest in critical care, I tend to lean more towards such questions. What should we always look for when we find an endotracheal tube or a tracheostomy tube on a chest X-ray?
The one thing we should look for is the carina.
Okay.
And then we should calculate the distance of the tube from the carina. First of all these tubes should be above the carina. If it is below the carina, something is wrong.
Right.
The second thing is the distance from the carina should be around 4 to 7 centimeters. Also,
I think generally we think that if there's a collapse on the left side, that is one of the common things we always see when the endotracheal tube has gone more towards the right side, and that's one of the most common findings.
The right bronchus is generally straight, so the endotracheal tube goes into it, and the right lung is now aerated well, but left lung is not aerated. Also, there is a tube in the trachea, so it will collapse.
So I would like to share this experience from a recent case. So this patient, he had left-sided consolidation, which was worsening, and he had been intubated. He was on NIV, not doing too well, and intubated. And it did not appear like the endotracheal tube is on the towards the right side. We did not expect the ET to be like poorly positioned. But when we went in there, the endotracheal tube was right against the carina. So, and there was a lot of secretion from the left side, which anyway were difficult to drain out for the patient or the expectorate patient had been intubated by the time he was getting secretions. But that's when I realized that we only look at the chest X-ray. Oh, if there's a collapse, if there's a collapse consolidation, or if the tube has been malpositioned, it's going towards the right main stem bronchus. But yes, we should look at the distance of the end of the tube, endotracheal tube, from the distance between the end and the carina. Thank you for that. Now coming to another interesting question, and I think this is something you like to talk about and personally interest you as well. So I want you to talk about hilum convergence sign and hilum overlay sign.
Okay. Thank you for that
question. I know that.
It is a difficult question. So to differentiate between the hilar masses. So if the vessels are converging directly onto the hilar shadow, then the mass is generally vascular. If the vessels appear to converge medial to the lateral aspect of the hilar shadow, then it is that is a mass.
Right.
That is mainly the hilum convergence sign. Then the hilum overlay sign is that if we can see the hilum through the mass. If we can see hilum through the mass, then the mass is either interior or posterior to the hilum. So that is hilum overlay sign.
Right. I know you talked about this in your PPT, but I just think this is an important sign and to be taught. So I'm coming to the last question for this evening, and this is a question that I think most clinicians will love. When should we have a chest X-ray in a patient with COPD or in a patient with asthma?
In COPD,
diagnosed case.
Okay. In COPD, acute exacerbation, very important. We have to do an X-ray to rule out other pathology. Right?
So I agree with that. Maybe there's nuances.
Or we have to exclude pneumothorax or pneumonia or pleural effusion or anything that is causing the acute dyspnea.
Perfectly said. And in asthma?
One is the similar. In children, it could be a foreign body.
Right. May I also add to see the ABPH, the asthma, and to rule out ABPH, we could get signs of bronchiectasis. And so that's also something we should look at. But as such, if in a patient who's a diagnosed case of, say, ruled out ABPA or no case of ABPA, and you don't want to, not suspecting, you're not having fever, you're not suspecting infectious etiology, chest X-ray may not be required. Do you think there's a space for us to think like that? That the chest X-ray may not be required?
Definitely. Clinicians order investigations. We are just there to interpret it.
Thank you so much. Thank you for a wonderful session, Dr. Nikhil. And I hope you enjoyed the webinar as much as I did. And I hope the audience enjoyed it even more. And thank you everyone for being here with us tonight. I thank the CCI team, which works endlessly, tirelessly to bring an academic, I would say, brain teaser, something, a food for thought, something for us, something to stimulate our thinking as practitioners, as chest specialists. I thank Dr. Krishna sir. I thank Dr. Narayan Pradeep, the founder, chair, trustees of CCI. And I thank the wonderful team, Dr. Atri, Dr. Chenam Chetty, Dr. Shivani, Dr. Rajadhar, and Dr. Ravi Dosi for all the efforts in making sure that every Thursday, every pulmonologist all over India, even abroad. I mean, I do know we have viewers from Dubai and from Nepal and from Bangladesh and Sri Lanka. So thank you very much for that. That every Thursday, every pulmonologist learns something. And I believe that at the end of every webinar, if we have learned even tiny, tiny bit, I think CCI has done its job. Wonderful. Thank you so much, everyone. Good night.
Thank you so much. Thank you, everyone.